Thank you for joining. Wednesday VMR. Steph and I missed the community and being here, and are excited to hear about a cool case and do some learning with everybody. So as always, we'll see if anybody has a case they'd like to share. And
Rafa said he's got a case.
Oh yeah, okay.
We just need two buddies.
Two buddies to discuss. What's new? Does anybody want to share some good news, or maybe something cool they learned recently?
I think the good news is Rafa's here and he's got a case in his new role.
That's right. Congratulations. New co-director of internal operations for the clinical problem solvers. Congratulations, Raphael. How's everyone else? What's new? What's good?
Well, I know there's students here. Match is done and over with. I think probably everyone is like few. What did you, Stefan Zaman, what was your match experience like this year? I know you guys do stuff with residents. How was it? How was this year compared to others?
It was really great. Hard to know. I'm curious to hear from others' experiences. It's, virtual interviewing is obviously very different, but here we are 2 years into the pandemic. We're so used to interfacing this way. Certainly those of us that get together and solve cases like this are kind of very comfortable. So with the virtual format feeling even more comfortable than last year, I think we got a good chance to really kind of sort of recruit and sort of show off for great groups of candidates. And we were really, really thrilled with it, and hope everyone else was equally excited about their next steps for next year.
Seems like every year the generations are getting more and more bright and accomplished and enthusiastic. That's my take.
Yeah, pretty much any faculty member on this call, I'm sure will have the sentiment of seeing all these fantastic kind of experiences you guys have, wonderful training of students, and thinking, "Ooh, I'm not sure if I would be able to get in now." But it's all a good thing. It just shows how much there is out there to get involved with and really learn a lot from early in your training.
And they're all smarter because they come to Wednesday VMR.
That's right.
All VMRs, all VMRs.
I still would love to hear if anybody wants to just kind of reflect back and think of just like one pearl nugget, concept or something they learned in the last couple of days that they want to share with the group. I've gotten in the habit of doing a round of that question with my teams, and where everybody has to just share like one thing, teach one thing at the beginning of rounds to the group. And I think it's a cool force function for people to like, think. And oftentimes it's really hard because I usually have to do the same, but it's really good to reinforce some of those learning points. So just type in the chat if you can think of something that you thought was good to learn and want everybody else to know too. Sammy, please.
Yeah, hi everyone. I'm currently on my anesthesia rotation, and today I was in OP10, in operating room 10 with my colleagues, and it seemed like there would be some boring operations and it would just nothing special would happen. But then suddenly we got the page that a man with an aortic dissection is gonna come to our OR, and it was like everything was crazy after that. I never saw that before. Everybody was functioning so perfectly, giving him the best care, from anesthesiology to radiology to cardiac surgeon, and I was there 6 hours and he survived. It was just crazy, and I was just thinking the whole day about that, what a pleasure it is to have such a good functioning medical system that can provide quick and supportive care for these emergencies. And I just wanted to share that.
Wow. That's, yeah, seeing something just urgent like that suddenly get well organized. And did the patient do okay after the surgery?
Yeah, he did well, actually. He survived.
Wonderful.
Thanks, Sammy. I love the pearls from Keshav and Gabriel in the chat. Thanks y'all for sharing. And Angelita, excited to see some of your thoughts in the chat, and understandable that everyone can't commit fully, but let's take a last call if anybody wants to discuss out loud with us. Otherwise, we can just get started with the case and try to engage people in the chat or PRN with unmuting.
Sounds
So
great.
I had a good, and I tweeted it out, an SBP pearl, and I saw a guy who was 30, in his 30s, alcoholic, liver disease, unfortunately. Maybe he has some inborn error like alpha-1 antitrypsin or something like that, but had SBP. And so talking about prophylaxis and antibiotics and how important they are. And so after the first episode of SBP, their recurrent rates are very high, about 70% at 1 year. And their survival rate among those who develop SBP is about 30 to 50%. For those who don't receive antibiotic prophylaxis. If you give antibiotic prophylaxis afterwards, that mortality drops from 70 to 20, which is huge. So not only after you treat it, they should be on prophylactic, whether it's a fluoroquinolone or a cephalosporin, depending on where you live in the antimicrobial resistance pattern. And then for primary prophylaxis, so never have getting it, and I didn't know this. This was something that I learned, that you can give primary prophylaxis if someone has a low protein ascites, less than 1 gram, and either impaired renal or liver function. Those patients are at risk for developing it. And it has been recommended to give in those who have acidic fluid total protein less than 1.5, and at least one of the following I mentioned: creatinine greater than 1.2, or a BUN greater than 25, or a sodium less than 130, or if they have a child Pew score greater than 9, or a total Billy greater than 3. And that was something that I learned just through looking it up. So I thought that was a cool little pearl.
wow. Thanks, Travis. Yeah. I didn't know those numbers, but it just seems like everything with SBP just has like the biggest effect sizes, right? So it's a really great reminder. Thank you.
All right, I think we're ready to roll. Hans and Victor are going to join us as we're getting the screen up. Hans, if you want to start and say hello, and then we can have Victor say hi to everyone. And we're excited to think out loud with you guys.
Yeah, I think I'm already known here. My name is Hans, and I graduated a little while ago. I was a clinical skills facilitator, and now I'm here and hoping to match in Canada. I'm not sure whether that's going to work out, but we are about a month later than you are with a match. Let's hope.
Good luck, Hans.
Hi, my name is Victor. I'm a Ghanaian general practitioner, hoping to match in the next cycle 2023 in internal medicine. I'm looking forward to discussing today. I'm currently in a clinic actually, but this is usually the down period of the clinic, so I'm hoping no patient comes. But let me apologize in advance if the patient does come and I have to go see to them.
No problem. And welcome, Victor. How great to see you seeing a case virtually when you could be seeing a case in person. So thanks for joining from clinic. All right, Rafa, we will turn it over to you to kick things off, and maybe do Hans and Zavin, you guys want to pair up, and
Sure.
Victor and I can, and maybe Victor, you and I can tackle the first section, and we'll take it from there.
Sure.
Awesome. Thank you everyone for coming for today's VMR. Pretty sure going to be a very exciting discussion. So for aliquot 1, I'm going to give you the chief complaint, a little bit of HPI. The chief complaint of this patient, he complains that he's unable to walk. This is a 45-year-old man that presents to the emergency department with a history of leg weakness for 3 years, with the regression to the point that he was unable to walk in the past 12 hours. This patient also stated a 2-month history of progressive dyspnea, fatigue, palpitations, and numbness in both legs and arms. And he denies febrile episodes, chest pain, or any other symptoms. And that's the end of the aliquot.
So leg weakness for 3 years, that's really worse in the last 12 hours, such that he can't walk at all. And then you said some tingling in his arms, Rafa?
And legs.
And legs. And then some shortness of breath. And was there one more symptom I missed?
Dyspnea, palpitations.
And palpitations. Whew. We've got a lot going on already, Victor. What are your thoughts hearing about this man?
Okay, so I'm going to focus first on the leg weakness. Usually when I hear of weakness in any way, I try to think of, is this a neurological disorder? Is it a neuromuscular disorder? Are we dealing with a muscular problem? For someone who has leg weakness, I'm assuming it's bilateral leg weakness from the way it was presented. So we're dealing with paraparesis. My first thought is always something going on in the spinal cord. And I would always want to know if it's spastic or flaccid, but I guess that would be brought up on the examination mainly, because the patient may not be able to report that. So for spinal issues, I mean, I would want to rule out any compressive disorders or something that might not even be compressive, like a transverse myelitis. Also looking at his, it's been going on for 3 years, so it's likely to be something that's more chronic in nature. So I'll be worried about a spinal problem maybe. But if I move past the purely neurological issues, I'm also thinking about neuromuscular problems. So does he have an issue at the neuromuscular junction? Are we dealing with someone who has a myasthenia? Probably unlikely, because he's going to present with maybe facial weakness, dysarthria instead of leg weakness, but it's a possibility. And then lastly, for the muscular issues, thinking of things like polymyositis, dermatomyositis, like issues of purely of the muscle that present with weakness. And of course, it could be systemic. He could have a hypothyroidism, but I was looking mainly at the dyspnea because of that. But yeah, that should be the palpitations that he's having could be a sign of a autonomic problem, and in that case I'll be thinking maybe of a Guillain-Barré syndrome, but 3 years is probably too long for that. So those are my thoughts right now.
Wow, Victor, that was fantastic. I really like how you kind of organized your thinking around the neuraxis, right? Anatomically, what are the regions from the brain down to the spinal cord, into the anterior horn cells, down to the peripheral nerves, to the junction of the muscles. And you named several kind of specific conditions for us to worry about, particularly with the spinal cord level, peripheral nerves, and the muscles itself. I think that's really well done. I'm also thrown off by the 3-year time course, to be honest. It's a really long time to have kind of leg weakness of unclear etiology. And I think we'll get more information, of course, on the exam about kind of the symmetry and some of the other things you were wondering about in terms of upper versus lower motor neuron findings. So I'm thinking in real life, knowing there's a 3-year context to some of the symptoms, I actually feel like sort of the more subacute and acute symptoms developing are probably where I would start my diagnostic process right now, knowing there's a background of weakness very, very chronically, specifically with the 2 months of worsening dyspnea, and then really the dramatically increasing leg weakness over just the 12 hours before he came in. You did such a nice job with the weakness. I don't think I'll add on too much more there, other than to say, I think your approach to the dyspnea and the palpitations and how it can overlie weakness also is really well done. You know, breathing and having our heart beat are, you know, fundamentally they're muscular conditions, right? First and foremost. So any kind of neuromuscular condition that could be causing weakness elsewhere in the body can cause neuromuscular weakness of the kind of chest wall bellows, the neuromuscular apparatus opening and closing. Similarly, any muscular disorders, right, can affect cardiac myocytes as well. So there might be a cross connection there at the muscle level. But a couple other things came to mind to me that can kind of cause cardiac, particularly electrocardiac symptoms, as well as peripheral neuromuscular symptoms. And that includes severe electrolyte abnormalities as a general category, profound hypokalemia, profound hypocalcemia. We've had other cases where we've seen those electrolyte disorders can affect our peripheral neuromuscular activity as well as our cardiopulmonary status as well. So there could be kind of a lot of different areas to unpack, but I have a feeling there's a lot more. So maybe we'll stop there and get more from Rafa.
Awesome, awesome. Okay, so I'm gonna give you a little bit of background and the physical exam. So past medical history for this patient, he said that there is none. When it comes to medication, he said no medications. Social history, he was born and raised in Brazil, no recent travel history, no sick contacts. When it comes, also he doesn't have like a smoking history, no drug abuse history, but he says that he drinks beer like 4 or 5 cans a day. No allergies, and his vaccinations are up to date. When it comes to the vitals, temperature is 37.5 Celsius, heart rate 130. His blood pressure is 160/70. His respiratory rate 45, and he's saturating 75% on VMR. On exam, his patient is in acute respiratory distress and fatigued. HEENT exam is remarkable for elevated JVD with collapsing carotid pulses. Cardiovascular exam, he has just displaced apical pulse at the 6th intercostal space, a 3rd heart sound, a holosystolic high-pitched bowing murmur, loudest at the left lower sternal border that increased with inspiration. His pulmonary exam is clear bilaterally. Abdomen, he has this mild hepatomegaly. Near exam, he has this symmetrical peripheral neuropathy, both in the hands and in the legs, like a stock of pattern. Extremities and skin, cold and cyanotic extremities, 2+ pitting edema up to the knees, and hyperdynamic pulses. And that's the end of the Aliquot.
Thank you, Rafael. What a thorough, excellent physical exam. Hans, take it away, please.
Yeah, in reading through the vitals, I'm tempted to include an infection as well, either a parasite, which Anne-Marie already mentioned, something like metabolic, which could have an effect on his nutrition, or some other infection. And it looks like he has a problem, almost like an endocarditis. We have almost a failing heart that causes a heart murmur, and we have we have a fifth heart sound, if I'm correct, and an elevated JVD. So the right heart seems to be affected as well. It could be the way I read the vitals, maybe a failing left heart, which eventually causes something like a pulmonary hypertension or affects the lungs, and secondarily affects the right side of the heart, causing an elevated JVD and already a mild hepatomegaly. Now, I cannot make any sense of his neurological signs unless, of course, we have something like a parasite or an infection that has been smoldering for many, many years, like a amoeba, something like this, a protozoan of some kind, which I'm not aware of. At first, I was thinking about a tumor or something like this in the spine, but now I'm more tempted to look at the center of gravity being the heart, and the spine somewhere is affected, or the other way around. So I pass the mic on.
Wow, Hans, amazing interpretation of the great exam that Raphael provided to us. And, you know, one thing I'll just kind of point out that is, you know, really important to pay attention to is, you know, just thinking about whether there's predominantly right heart failure signs or left heart failure signs, right? Because when it's isolated, just one or the other, the differential shifts a little bit. Right? Is this mostly just pulmonary hypertension, sort of right-sided failure, or it's mimickers like constrictive pericarditis, for example? Or is there also left heart failure, right? So in this case, of course, there's dyspnea, but the lungs are clear, and, you know, despite the fact that there's hypoxemia, so it's a bit of a mixed picture. So actually defining the cardiac kind of lesion would be really important to better drive the differential. The contrast is if you have somebody who's presenting with predominantly pulmonary edema, but not a lot of kind of right-sided failure signs, not a lot of, you know, edema, volume overload sort of globally, you think about a different sort of differential, sort of what you think of as causes of flash pulmonary edema, things like, you know, left-sided valvular lesions, which may be more acute, things like intermittent arrhythmias, you know, LV ischemia, etc. So I think that was really important to try to tease out, and we definitely need sort of an echo to define that further. But I want to kind of zoom back out and just, you know, kind of continue the discussion, Hans, with the neurologic syndrome that you ended with, which is, you know, initially it seemed like this was a neurologic syndrome, and certainly, you know, what Rafa described as sort of an exam consistent with sort of peripheral neuropathy. I'm assuming some, you know, some signs of sensory loss, you know, dysesthesia that is symmetric. I would also kind of want to look for weakness that is more distal than proximal, for signs of atrophy in the hands, you know, and in the feet. But if this is sort of, if we are accurate in our impression right now that we're dealing with a peripheral neuropathy, a polyneuropathy, and then heart failure, you know, you could think of the overlap between those two syndromes. So Thymine Deficiency, you know, was mentioned multiple times, I think, in the chat already, and certainly this person's at risk, and it can both cause heart failure and peripheral neuropathy. You know, ethanol itself, right, is one of the most common causes of peripheral neuropathy and cardiomyopathy. So just that could explain things. Amyloidosis, right, can cause heart failure, peripheral neuropathy, also in that you know, Venn diagram. And then I do, you know, like Hans, you sort of invoking the infectious differential, especially with that abnormally elevated temperature, right? That's not a normal body temperature for a middle-aged man, and I'm not sure sort of what to make of it. I can't, you know, the syndrome and the chronicity of it I think some parasitic infections can certainly cause pulmonary hypertension. Less so that I'm familiar with this neurologic syndrome. But good to sort of keep on the list and revisit as we get more information. I do want to point out, though, within the differential of sort of heart failure polyneuropathy causes, one unique feature here in the hemodynamics, all right, which is the fact, oh, Gabriel, that's exactly what I was going to say. That pulse pressure is weird, right? The pulse pressure, the difference between the systolic and diastolic blood pressures essentially is a factor of your vascular tone as well as your stroke volume. And that pulse pressure, along with the palpable pulse pressure, the bounding pulses that Rafael told us about, is suggestive of a large stroke volume. So this patient is in heart failure. Every time the LV is squeezing, it is squeezing a huge amount of blood. So what can cause that? Well, one thing is chronic aortic insufficiency. It can certainly, cause that syndrome. The murmur we're hearing sounds more like tricuspid regurgitation than AI, right? It should be diastolic and in a different location for chronic AI. But the other things that can cause a high pulse pressure are everything that you think of as causing high cardiac output, right? And all the things that can cause high cardiac output heart failure over time, severe anemia. I guess if the hemoglobin is 4 here and the B12 is undetectable, you could have polyneuropathy and high output heart failure. Thyrotoxicosis, peripheral neuropathy, we think of it as, thyroid abnormal states can cause, but not very typical actually. But thymine deficiency just shoots up to the top when you have this syndrome. And actually, it's so funny. I saw a patient recently, Rafael, that presented like almost identically to this. And that was our final diagnosis when we really ruled out everything else and gave him IV thymine, and everything got better. So let's leave it at that and move on, unless Steph, if you have something to add.
I just want to, Anna made a good point, a good observation of this very low saturation of 75% with clear lungs, but in the setting of a clinical picture of a dilated cardiomyopathy, where at least with the physical exam of the PMI displaced laterally, the left heart probably isn't normal. So I'm curious, either for Victor or Hans or Zavin, sort of how you guys are reconciling the totally clear lungs, but with a very low oxygen saturation and other signs of potentially biventricular heart failure. I don't know, Victor or Hans, you guys have any thoughts on that?
Okay, so I was thinking about that because if it was low SpO2 secondary to pulmonary edema, I would have expected to hear some maybe fine crepitations. So the possibility of amyloidosis was brought up, or any disorder that can cause maybe total body fibrosis. You could have, it could explain for your peripheral neuropathy, explain the heart failure too, and then maybe there's some ongoing pulmonary fibrosis that is not going to be picked up by your clinical examination. The other thought is that maybe if this memo we are hearing is a VSD and is allowing, and he's been having it for a long time, and it's allowed for shunting to occur, like an Eisenmenger complex to develop, then that could explain the cyanosis that he's presenting with, and the low SpO2s that he's presenting with. Yep.
Great thought. Yeah, I think we can explain it a few ways. Is there actually a right to let shunt? Because we do see this man is cyanotic, right?
Yeah.
So I think that's an important thing to think about. with really long-standing heart failure and chronic left-sided heart pressure elevations, you do over time, right, get compensatory lymphatic hypertrophy and the ability to clear out some of that extra fluid in the lungs. Now, this is a fairly subacute story, so I don't think that compensatory physiology fits here. And then I just want to point out, presumably this was done with a pulse oximetry, and if this man is cool and cyanotic, it's also possible the pulse oximetry is just not actually picking up an accurate saturation there. So we'll, I think, see probably more with the labs, but it is a striking thing that Anna pointed out, clear lungs, but a very, very low. And I think it makes us have to think a lot about reasons the pulse ox can be low, both technical reasons as well as physiologic reasons that drive hypoxemia. And shunt is just a great thought, Victor.
Thank you for pushing that forward, Steph. I think it's a really important thing here. So if we confirm the hypoxemia with the ABG, then and the clear lungs with the chest X-ray, if the lung parenchyma are clear again, then you sort of significantly limit the differential for sort of mechanisms of hypoxemia, and one would be hypoventilation. So, but the ABG would tell you that too, right? So if the PCO2 is very high and there's little to no AA gradient, okay, that's all it is. But if it's not hypoventilation, then shunts would go way up. And I just want to mention, in addition to intracardiac shunts that are mentioned, the possibility of intrapulmonary shunts also exists. And one other cause of both that, as well as the high cardiac output state, as well as some of the findings on the exam, could be liver dysfunction and cirrhosis. We didn't hear a lot of stigmata of chronic liver disease on exam, but again, you don't see what you don't look for necessarily. So it's good to consider that possibility too.
All right, Rafa, we're ready for more.
That would get this echo with bubbles, right?
Yeah.
Okay, so the notable labs, his sodium was 122, potassium 3.5, his bicarbonate was 10, chloride 80, calcium 11, hemoglobin 14 with an MCV of 110. His white blood count was 16.5, and his platelets were 60,000. BUN 10, creatinine 1.5, glucose 200. His AST was 110, ALT 60, alk phos 200, GGT 1009, and total bilirubin 2.6. His albumin was 3.5. His PT was 12.8, elevated, and his PTT was 38 on the upper normal limit. We indeed draw arterial blood gas, and the arterial blood gas showed a pH of 7.3, a PCO2 of 9, a PO2 of 152, and a bicarbonate of 5, and a lactate of 13. A chest X-ray was obtained and only showed chiromagaly, and a cardiac ultrasound showed hyperdynamic heart with dilated chambers, and the EKG showed a tachycardic sinus rhythm. And that's the end of the aliquot.
Whew, we've got a lot more to unpack here. Victor, do you want to just tackle your thinking on some of the labs?
Okay, yeah, that is a lot. So let me start with the hematology. The white count is raised, so I would have liked to have gotten a differential on that to know exactly what sort of, what I'm dealing with, the neutrophilia, leukocytosis, or something like that. The hemoglobin is normal, but we have a high MCV, which could speak for the B1 deficiency, alcoholism with the B12 deficiency, maybe even a folate deficiency. And that would make sense in a setting of a beriberi from vitamin B 1 deficiency. The platelets, I honestly am not sure why it's at 60,000. It could be linked to a whatever infection he might have. If it's a viral infection, maybe he's developed a sort of response to that. I honestly am not sure. Sodium is low, but I would have to think about why he's having hyponatremia now. If I go down to, yes, his AST and ALT. AST is elevated and is about 2 times the upper limit of the, the ratio of the AST to ALT is about 2:1, which speaks for an alcoholic liver injury per se. I would have liked to see if he had a raised GGT2. That would have helped me out. The albumin being low also talks about points to a chronic liver disease. And for the ABGs, I'm honestly not confident enough to interpret it, so I'm going to have to leave that be. The tachyarrhythmia seen on the ECG could just be a response to his cardiomegaly, to the heart failure. So I don't think that gives us too much information. But from the labs right now, I'm beginning to lean more towards heart failure secondary to dilated cardiomegaly due to vitamin B1 deficiency. Yeah.
Beautiful thinking, Victor. I like through all of these abnormalities, and there is a lot going on with these labs. You're not losing sight of this problem representation we have of peripheral neuropathy, dilated cardiomyopathy, thinking of the overlap we've come up with and which of these labs fit in. I'm looking at the time. There's a lot to unpack here. I'll just kind of quickly comment on the labs, and I'll get into the ones that I think might be more helpful diagnostically. And I'll tell you which ones I think are less helpful diagnostically because of their either sort of lack of specificity or the fact that we're not surprised to see them in this case. So the leukocytosis, not too surprising. This guy is sick, stressed. I think we leave it at that. The high MCV, Victor, I think your thinking is spot on to think about what's driving that. And it's kind of a shorter list that can cause an MCV to be that high, including B12, which you mentioned, liver disease itself, severe thyroid dysfunction can also, alcohol use also causes a high MCV. And then once you've excluded all of those, you can think about myelodysplastic syndromes. Folate deficiency is the other nutritional deficiency. So in this person who has chronic alcohol exposure, it's not too surprising, but the MCV may end up overlapping with our final diagnosis. The low platelets, I don't think are going to be too helpful diagnostically. I think he's got a lot of reasons, including chronic alcohol use, to have thrombocytopenia. The sodium 122 is scary, but I don't think a big mystery in him, given the hypervolemia that we're seeing on exam. I think if we did more of an evaluation, we'd see that this is from appropriate ADH in the setting of a low perceived intravascular volume in this person who's actually quite volume overloaded with a very active renin-angiotensin aldose system. The bicarb of 10 and the ABG, I do want to talk about also in the context of this lactate of 13. So I will give you just a very brief approach, Victor, to ABGs. And that is to say, very first thing, look at your pH and see, is there acidemia, meaning it's less than 7.4, or is there alkalemia, meaning it's greater than 7.4? And I want to tell you guys, I'm being very deliberate saying acidemia instead of acidosis, because we will see, as is the case here, very often there are alkalotic as well as acidotic processes happening at the same time. But the question is, who is pulling the pH in which direction? And in this case, we're acidemic. And it's a metabolic acidosis because we see the bicarb is abnormally low, indicating a metabolic acidosis is probably driving this acidemic pH. And from there, I'd say the most important things to do are see if it is a primary metabolic acidosis? Is it due to an anion gap or not? And I saw someone in the chat had calculated there's a very high anion gap here of 32 or so that we'll have to figure out. And then the final step I would say is the respiratory status doing just exactly what it should to compensate, or is there another respiratory problem going on here? And in this gentleman's case, his PCO2, if all his lungs were doing were compensating for the metabolic acidosis, should be what Winter's formula gives it, should be our bicarbonate times 1.5 plus 8. And his PCO2 of 9 is way lower than it should be of about 15, 16, 17. So this gentleman has a big anion gap metabolic acidosis, and on top of that, a primary respiratory alkalosis going on. That lactate of 13 is a big part of the anion gap. I'm sure you all have different methods and mnemonics for anion gap metabolic acidosis. This lactic acidosis is a big one. And I think the big things to worry about with his lactate are, is this because he's in shock? And this is a sign of malperfusion given this decompensated heart failure. Or back to our thiamine consideration, is this what we call a type B lactic acidosis, a lactic acidosis because of a mitochondrial deficit, and B1 is an important cofactor actually for lactic acid metabolism. So I think that ends up giving a potential signal for what you're still wondering about, Victor, which is the vitamin B1 deficiency. I don't have too much else to say about the echo. I think it's notable that it's hyperdynamic also. We've alluded to sort of high output heart failure being on the table here, both to fit with beriberi as well as that high pulse pressure we talked about. Rafa, how many more aliquots are there? Because I want to see if Hans or Zavin want to jump in, or if we should get more info for you.
No, we just have, let me see, one more aliquot, and this is the echo and the right and the heart catheterization, and then the final diagnosis.
We keep moving then, get a little more info, or I don't know if Hans or Zavin want to. There's a lot going on in the labs.
Yeah, we can keep going. Shoot, there was one. What we already have an echo though, right? No cardiac ultrasound, or it's no? Oh, okay.
Only the ultrasound.
Cool. Yeah, and we didn't get a TSH, right? Yeah, I think that the biggest thing on my mind right now is just the fact that like life is multifactorial and medicine is multifactorial, and in this case, and in most patients, you know, there's more than one thing explaining various abnormalities. And I think that's the challenge here, trying to tease out and then not miss like an additional thing. You know, what if the peripheral neuropathy is just alcohol? It has nothing to do with this presentation. And, you know, this is, you know, there could, and the patient is thiamine deficient, right? But they're also thyrotoxic, which might explain the elevated temperature, for example, better than anything else we've mentioned so far. So anyway, that's I think the biggest challenge for me right now, and just realizing that just because you found one thing doesn't mean there's not also several other things. Rafael, let's hear more.
Okay, so I'm going to give you all the information before the final diagnosis. So the echo showed a left ventricle ejection fraction of 75% with dilated right and left chambers, tricuspid regurgitation, and pulmonary hypertension. And his right heart catheterization showed increased cardiac output, increased cardiac index, decreased systemic vascular resistance, increased CVP, increased pulmonary artery and pulmonary capillary wedge pressures. And that's the end of the aliquot.
Thank you, Rafael. Hans, what do you think of those numbers?
I don't have the numbers yet on the screen. We have a hyperdynamic heart with, well, that's the ultrasound. The echo showed an ejection fraction left, which was 75%. And right heart catheterization showed increased cardiac output, increased cardiac index, decreased systemic vascular resistance, increased, now we got it, CPP, and increased pulmonary artery and pulmonary. It looks, a vague suggestion that I have from this one could be more like a diastolic heart failure, where the left, or the volume of the left heart somehow seems to be diminished and causes a backup into the lungs. This could explain a hypertension of the lungs and the JVD, as well as probably the liver problem that he has, that we have it at the beginning, abdomen mild hepatomegaly. But I cannot yet explain, in a way I can explain his low SpO2 from the pulmonary hypertension. This could cause the lactate to be up, and this could give rise to some of our lab values. But I do not know the reason for his heart failure. It just seems like a diastolic heart failure with preserved ejection fraction. But the underlying reason why he does have it, I'm not sure. Could it be from his alcohol? So it is because he was drinking 4 to 5 beers a day, that this could have an effect and on his heart, an alcoholic heart failure. And the heart failure might also explain the low sodium and possibly a metabolic effect as well, with maybe low B12. But I cannot yet make up the reason why he has low platelets. B12 could explain low platelets, but we have a normal HB. But that could be, again, a counter reaction from the kidneys, because if he does have low SpO2, we might have high erythropoietin and then a high production of red blood cells secondary. And the high MCV might, so there's probably two things that could be related to his alcohol consumption somehow.
Absolutely, Hans. I think both the MCV and the low platelets could be direct effects of ethanol on the bone marrow. But I think always a good idea to make sure you're not missing an easy and serious vitamin deficiency like B12 in addition. Yeah, I think that, you sort of said that this patient's clearly in heart failure. We know he has elevated pulmonary pressures, and the EF is preserved and the cardiac output is increased. We sort of have all of those data points, and now the biggest challenge is just trying to think about what can cause all of those things. Let me just share the screen real quick and show a slide that will be helpful as I talk through this. And it's a way of thinking about pulmonary hypertension. Ignore the cirrhosis part real quick. But this is the same formula that sort of governs hemodynamics. It's kind of like Ohm's law, that we learned for physics. But basically, the driving pressure on the pulmonary side, it's mean pulmonary arterial pressure minus left atrial pressure, is cardiac output times pulmonary vascular resistance, right? That's BP equals CO times SVR, that's V equals IR. And if you solve this equation for the mean pulmonary artery pressure, the elevation of which defines pulmonary hypertension, you see that there's 3 terms left: cardiac output times PVR plus left atrial pressure. So this is helpful in a couple of ways. One is to realize, sort of like very simply mathematically, why left heart failure is the most common cause of right heart failure. Because if your left atrial pressure is elevated, your pulmonary artery pressure is going to be elevated. And that's always an additional helpful and critical value to know when you have a right heart cath is what were the left atrial pressures to see whether the pulmonary hypertension was sort of potentially or fully or partially explained by that. The other thing it helps you realize is that any high cardiac output state will elevate your pulmonary artery pressures. If this term is high, this term is high, done, right? And only if the left atrial pressure and that cardiac output are normal, oftentimes can you say that this is true pulmonary, like arteriolar hypertension, a problem with the pulmonary vascular resistance itself, such as you see in group 1, pulmonary hypertension. And along with this, I also just want to plug a brand new episode of Core IM that just dropped that I haven't listened to yet. I've just looked at the graphics, but that goes over the various causes of pulmonary hypertension. And I'm excited to check it out. I hope y'all will too, in terms of the full episode. But going back to the case, I mentioned that multifactorial, lots of things could be going on. Let's get practical here. I think the one diagnosis that has come up over and over that I think could unite everything is Thymine Deficiency. It could cause the neurologic symptoms, the lactic acidosis, which is definitely not from global hypoperfusion in this high cardiac output state, right? As well as the high output heart failure and the syndrome. So what we need to do is we need to empirically treat that top hypothesis and have time and follow-up be on our side to see how this patient does over the next couple of days. When you do have heart failure caused by severe wet beriberi, things often improve over a couple of days, and that itself would be a very important signal. And then, as I said before, we also can't miss thyrotoxicosis as a cause of the syndrome, and that's so easy to rule in or rule out with simple laboratories that I think it's an important thing to do in addition. And I think once we sort of test those hypotheses and see how things go, then we can sort of go to the other possibilities, as well as maybe revisiting the right heart cath numbers a little bit more closely to try to see if there's a transpulmonary gradient or not, or if everything is explained by the cardiac output and left atrial pressures. Bring us home, Rafael, please. I'm dying to know what this patient had and how they did.
Congratulations, you just saved your patient. So due to the severe acidosis, the hyperdynamic circulation, and the biventricular enlargement associated with alcohol abuse history, this all suggests wet beriberi, and the low thiamine level that I didn't tell you, but it was collected, it was low and confirmed the diagnosis. So this patient condition improved after thiamine administration in vasopressor treatment. Just to give a pearl that I learned from this case is that thiamine deficiency causes beriberi. And beriberi can be characterized as dry or wet, depending on cardiac involvement. Dry beriberi is only symmetrical peripheral neuropathy of the distal extremities, resulting in sensory motor impairments that this patient had. But wet beriberi includes all of these in addition to the cardiac involvement with high output congestive heart failure. And just a clinical pearl that when beriberi is suspected, furosemide should not be used in these patients. Furosemide administration is related to thiamine deprivation and causes increased urinary thiamine excretion, worsening the thiamine levels. And that's the end of the case.
Steph, about the Lasix? That sounds like vaguely familiar, but if I ever knew it, I had completely forgotten it. And thank you so much, Rafael, for reminding us. Wow, amazing. Thank you for sharing this case. Vivek or Keshav had a great question. Why did the weakness worsen over a day? I think this is where too, like weakness too is multifactorial, right? You might have bad nerves, but suddenly when you also superimpose severe metabolic derangements right? Hypoxemia and other thing, and just sort of like dyspnea, cardiopulmonary insufficiency, suddenly you fall off a cliff, right? And it's also just an example of how you can compensate, but there's a breaking point, an inflection point where you can just sort of, even chronic processes can suddenly accelerate over a shorter time course.
Awesome case, Rafa. Really just so much to work through. Thank you to Victor and Hans for chatting and sharing your thoughts. Also really learned a lot and appreciate all you guys being here on this Wednesday VMR. We will see you all soon. Have a great afternoon, morning, evening, wherever you are.